Good morning. My name is Heather Cox, and today I'm going to speak with you about insertion of a nasogastric tube. The first thing I'm going to speak to you about is the different types of tubes that are available to be inserted. Based on your doctor's order, you would want to confirm what type of tube has been ordered, and then you certainly want to go back and review the purpose for the tube. I'm going to show you the different types of tubes here first. You will notice that they are used for different purposes and they appear different. The one we're going to place in today is actually what we would call a Salem sump tube. This one is primarily used for gastric decompression, to help with abdominal distension, and also to suction out secretions and things if your patient ends up having a bowel obstruction or if they're having other issues which cause gastric distension. Whenever you take the tube out, and we'll look at it later, you would notice that it has holes at the end, and I'll actually go ahead and pull it out now and show you. At the end of the tube, it does have holes here all along the end, and that allows for the air and the secretions to be suctioned up the tube. The tube also has, in most agencies, markings all along it, so that will help you whenever you go to do your insertion to know the level and to be able to remember how far the tube is in. It also has another port here at the end, which is the air vent, and this allows for patency of the tube. As you look at the other tubes, these are primarily used for feeding and medication administration. And you'll notice these are a lot more flexible than the one that's actually used for the suction. And on most of these tubes, they have holes at the end to allow the medications and the tube feeding to enter the stomach. They are also marked usually with markings here for the length of the tube as well. Another example would be one of the Levin tubes that can be used for feeding as well. It actually has two in it. If you'll look with it, it has holes along the bottom which would allow feeding and medications to come out as well. It does have markings, but there are no numbers on it. So this shows you the different types of tubes that could be used for either suction or for tube feeding or for medications. So outside the room before you go in, you always want to make sure that you have looked at your doctor's order and you're aware of the right patient and what it's ordered for, the purpose of the procedure, so that you make sure that you gather the right equipment before you go into the room. Thank you. So, outside the room, we already confirmed the doctor's order and the need for the procedure that I'm getting ready to do. Thus, it would help me to gather the equipment that I would need, and I'm going to go through that in just a minute. As I'm coming into the patient's room, I'm always going to knock. I'm going to go ahead and foam in as I enter, and then I'm going to perform AIDIT. Hello, Mr. Smith. How are you doing today? I'm going to acknowledge the patient, and he would be interacting with me, and hopefully he would tell me he's not doing well or he's doing well, however he's feeling. I'm going to go ahead and introduce myself. My name's Heather. I'm going to be your nurse today. I'm going to go ahead and speak to him about the procedure that I'm going to be doing and the duration of it. Mr. Smith, we're going to be inserting a nasogastric tube today because you're having some abdominal distension, it sounds like, and some discomfort. Apparently they did an x-ray on your stomach and they found that you've got an intestinal blockage. The procedure that I'm going to do is a little uncomfortable, and there's going to be a tube that goes from your nose down to your stomach, and it's going to help decompress or suction out all that extra air and secretions that you have in your stomach, and hopefully that'll help prevent you from throwing up and help with the pain that you've got going on. So I've acknowledged and I've introduced. I've also explained to him the procedure that I'm doing, and I've given him a duration. Certainly before I leave the room, I'm going to thank the patient for allowing me to care for him today. I'm also going to go through and confirm with him, Mr. Smith, do you have any allergies, especially to latex or anything like that? And whenever you go through your equipment, you're going to want to make sure that there is nothing in there that is latex related if he has latex allergies. I'm going to go ahead and explain to him that I need to sit him up in a certain position to allow insertion of the tube. And I need to establish with him in some manner that as I'm doing the procedure, if he needs me to stop, he needs to either let me know verbally. If he can't speak, he could raise his hand. He needs to communicate with me in some manner throughout the procedure. So I've explained to him what we're doing and why we're doing it. And I'm going to get him positioned in a minute, but the next thing I'm going to do is flip back over to the table, and I'm going to speak to you about the equipment, because certainly before you start any procedure, you need to make sure that you have all of the equipment in place. So you needed to have been mindful before you came into the room to make sure that you're completely prepared and not leaving and re-entering. So what we're going to do now, we're going to go through the different equipment that you might need for insertion of the nasogastric tube. And as we discussed before, the tube that I'm going to put into Mr. Smith, this one is actually a Salem sump tube, and this one is used primarily for decompression of the stomach from gastric secretions and active air. Now, the size of your tube will vary on the size of your patient. I'm going to use what we call a 12 French on Mr. Smith because he's the mannequin and this is the size that will go into him the best. Typically on an adult patient, you would either use a 16 French or an 18 French. If you have a pediatric patient, you tend to go down in size, and with the French system, the lower the number, the smaller the size. So a 16 and an 18 French are certainly going to be larger than this 12 French that I'm using for Mr. Smith. Normally he would either get a 16 or an 18 French. So for a pediatric patient, 10 French to 12 French, and if you go on down to neonates, you're probably getting on down into 5 French or even smaller than that. So I've picked out the appropriate tube. I've got the appropriate size for my patient. Whenever you look at your packaging, as you would do with anything that you're doing, you need to make sure that the package would be clean, dry, and intact, and that the expiration date is within the time frame. You also need to make sure that if your patient has latex allergies or anything like that, that this does not have that in it. Mr. Smith does not have those allergies, so we're okay. As I open this up, I would want to make sure and go through and assess the tube and make sure that the tube is patent and that there are no issues with it. This is not a sterile procedure, so you do not have to be sterile for this, but certainly I wouldn't want to be flipping it all around and getting it dirty in other manners. As I take it out, I'm going to look at the tube again, and we had discussed some of this earlier, but this one is the Salem sump tube, so there's some differences with it. And as you look at the end, you do have the holes all along the way that will allow for suction and decompression. It sucks out the air and the secretions. You can actually administer tube feed and tube meds through this tube, but primarily it's used for decompression of the stomach. If you look at it, it does have markings all along the way. So you can see we've got the 10, 11, 12, 13, 14, and 15. So each one is a 1 centimeter marking, and this is helpful for whenever you actually insert the tube to the patient so that you can remember what mark it is at the nair, and that way you can see if the tube has been dislodged. Also, as you move to the end, you will note that it has 2 holes here. This hole right here is primarily where you would actually attach your suction control and the tubing so that you can actually suction the patient, and this other tube correlates with the actual air vent, which helps maintain patency of the tube. Another piece of equipment that you would need would be something called an anti-reflux valve, which goes along with this Salem sump tube. Again, check the package, clean, dry, and intact. Expiration date is within normal range. When you take this out, you will note that there is a blue port and there's a white port. Anytime you insert this into the air vent, you always want blue to blue. The reason for that is this anti-reflux valve has an open end in the blue port, which goes into the actual air vent, and then the white side has air vent holes. Thus, since there's an open end here and holes here, it allows for air to escape and helps maintain patency of the air vent of the Salem sump tube. Another purpose for this anti-reflux valve is once it's placed into the patient, you certainly wouldn't want to leave this open because you could have air entering the patient or escaping and secretions escaping the patient. So you can also use this to put the white end in here to actually clamp the tube, so if the physician orders it to be clamped. I've now got the appropriate tube and the anti-reflux valve. So I need to move on to other equipment. So I've certainly got the right tube and the size and all of those kind of things. There are some things that will help me ease insertion of this tube into Mr. Smith. So whenever I go over to him, I'm going to get him in the right position, and I'm going to go ahead and do that now and speak to you about some of the rest of the equipment as I do it. All right, so I'm going to go ahead and raise Mr. Smith's bed up to a height where I can reach him. And then I'm going to raise his head up to at least high Fowler's position as long as he can tolerate this. This helps ease with the actual insertion of the tube. Okay, and as long as he can tolerate this, and he may be having some abdominal discomfort and he may not be able to sit up this high, he tells me he's okay, so I'm going to leave him at this level. To move on with other equipment that I would need, I would also need a waterproof pad, and I'm going to apply that on him at this time. And then I would also need an emesis basin for him, because one of the reasons that I might be inserting this tube is because he might be having vomiting and nausea and all that stuff. And certainly whenever I'm placing the tube, it might cause him to throw up. Another thing that could ease insertion would be actually to have him drink during the procedure. Now, very commonly, we'll have a second person in here to assist us to hold the liquid and to encourage him to drink whenever it's the appropriate time. I'm in here with him by himself, so currently I'm going to hand this to him. And when it's time, I'll have him actually raise the cup up to his lips and drink, which helps him swallow the tube down to his stomach to keep it from going down into the trachea and causing him airway issues. Anytime during the procedure that he has any distress, I've already established a way for him to communicate with me, but there are other things that I would need to be making sure that I watch for. You'll see that I have a pulse oximeter on him. This is always a good thing because the tube is supposed to go nasogastric, which means it goes down the esophagus into the stomach. Sometimes it can end up going down into the trachea and toward the lungs, and then your patient could have complications and you could see the pulse ox drop. You might see him become cyanotic or discolored, okay, and he might start coughing or having issues with breathing. And certainly if he's doing that, some of the other equipment that I'm going to use to look, I would also have a tongue blade and I would have a pen light here so that I could have him open up and I could look at the back of his throat and make sure that the tube hasn't curled in his throat or that he's not having further issues with it. So I do have the pen light and the tongue blade available. The other equipment that I would need, I'm going to flip back over to the table for just a minute because I have him prepared here. So we've set Mr. Smith up over here with his waterproof pad, his emesis basin, and his water. Certainly I would need to instruct him that he doesn't need to drink anything until it's time, and I've indicated for that to occur. Again, he might well be MPO, and he may be ordered to be to suction. We don't want a lot of extra liquid in there for him to have issues and start throwing up. The next thing I'm going to do is look down at the table again and discuss further equipment that's needed for the procedure. All right, so we've already established the tube and the actual anti-reflux valve to maintain patency of the air vent. We've got the tongue blade and the pen light, which will assist us in looking for complications while we're placing the tube. Some of the other things I'm going to need here, once I get the tube placed, a couple of different things you can do to make sure you're at the right level and maintain. Once we measure, you can use an indelible marker here to actually mark the tube, or like we said, it's marked with centimeter markings. You can also have tape that you can use to mark it all along the way. Once the tube is in, you would want a skin prep for the nose, and then one of the securement devices, okay? And sometimes you'll see them actually secure it with tape, but most of your agencies have actual securement devices that secure to the tube and to the patient's nose. You will certainly need some lubricant. It will need to be a water-soluble lubricant to lubricate the tube before we place the tube. In here for our mannequins, you'll very commonly see us use the airway lubricant. So I won't actually be lubricating this tube for Mr. Smith. I would be using the airway lubricant on him, and I've already done that. In your real patient, however, you would want to make sure that you've used water-soluble lubricant. Whenever you're checking for placement of the tube, there are several different ways to go through and do it. Certainly a chest x-ray is the most accurate way to check placement, but other ways would be to have some pH paper, and you could put it in an emesis basin, and so when it's time you can actually put some of the gastric secretions in here, and you can watch for the change in color. Typical gastric pH, according to your textbook, should be less than 5.5. Most gastric secretions you're going to see range from 0 to 4 in pH. So I've got some pH paper in here. Another way to check placement is to actually have a tape measure, and you can use a disposable or you can use one of the retractable ones. So you'll also see me use this, and you would measure from the patient's nose to the end of the tube, which would actually be to this end right here. Then you're going to need something to secure this tube to the patient's gown, and usually what you'll find that we use is a rubber band and a pin. You're going to want to make sure that you never stick the pin through the tube, obviously, because then it could cause a hole, which could cause leakage of secretions and things out onto the patient's bed. Some other equipment you're going to need would be one of the piston irrigation tray sets, and this actually comes in with it with a waterproof pad, and it has a tray, and then there's going to be a canister with the piston irrigation syringe in it. You might also need some irrigant, and here you'll see we have sterile water, but this depends on your hospital or agency policy. Most of your agencies are probably going to be using tap water, but please be careful with too many tap water irrigations because they can alter the fluid and electrolyte status of your patient. So always make sure you check hospital policy for what type of fluid you should be using. I'm going to have some tissues here. So as I'm inserting the tube, if Mr. Smith feels that he needs the tissues, then I would have those on hand. And then at the end of the procedure, I'm going to have some things so that I can provide for mouth care. And you also always want to examine your patient's nares for intactness and make sure that you're keeping up with that. I'm now ready to get started with the procedure, so I'm going to go ahead and proceed on with opening up some equipment and getting prepared to move over here and do some things that I need to do. And as I'm ready to get started with the procedure, I'm going to wheel the table over here a little bit closer to Mr. Smith. I had already discussed that we need the barred piston irrigation set. As with any equipment, when you open it, always make sure that it's clean, dry, and intact, and that it is within the expiration. And please be careful with this because at some of your agencies, there is another that closely resembles this one, and it's actually a catheter urethrization tray. And you want to make sure that you grab the one that says piston irrigation set because that's the one that you need. So as I open this up, as I had said before, it actually has a waterproof drape in here. Of course, you got to move some things around to make sure you've got enough room on your table for everything that you need. And when I open it up, you'll actually see in here that I do have a tray. And you could have used this tray to put your pH paper in instead if you needed that. You're also going to have a container for whatever liquid you're doing your irrigation with if that's ordered. And then when you open it up, you're going to have the piston irrigation syringe. And if you'll note on it, it has markings all the way up to 70 milliliters. It also comes with a smaller extension. Usually you won't need this for your Salem sump tubes, but sometimes you may need it on the end for some of your feeding tubes and things. So what I typically do is put it in the tray and save it. I usually go ahead and maneuver the syringe a little bit to assist because sometimes it can be a little stiff whenever you're first opening it. The other thing you'd want to note is if this was at the patient's bedside and it had already been opened, you will want to make sure that it is date, time, and initialed because most of your agency policies require that this be changed every so often, usually at least once 24 hours, because they can harbor germs and you don't want to introduce those to your patients. So at the end of the procedure, I would certainly want to date, time, and initial this so you would know when the last time it was changed. Now, if there's any extra packaging or any of that kind of stuff, then I'd probably want to get rid of that off of my surface so that I have some extra area to be able to maneuver around with. I usually go ahead and put the emesis basin with the pH paper up here on the waterproof drape so that I don't make a big mess. If I have not moved my trash can over, I could do that now with my feet and throw my extra packaging away. Please remember, anytime you touch the trash can, you must wash your hands or foam in again. At this point, I'm going to go ahead and refoam again. Never hurts to do it more often than what you need to do. I've already explained the procedure to Mr. Smith. And so I need to go ahead and move on with the measurement to make sure that the tube goes in the appropriate level and place and all of that. So I'm going to go ahead and get out the Salem sump tube that I'm putting in. Again, this is not a sterile procedure, but you don't want to allow it to, touch all the surfaces and things. In order to measure, think about where the tube is going. So this is a nasogastric tube. Therefore, it's going to enter his nose, go to the back of his throat, and it's going to sit down here in the epigastric area. So you need to make sure that, yes, I do have the waterproof drape over the patient, but I need to make sure that in some manner I can see his epigastric area when I need to. When I'm measuring then, I'm going to come with the tube, and I'm going to measure from his nose to his ear, or the back of his throat, and then I'm going to measure down to the epigastric area. And for him, it looks like it's somewhere around 60 to 62 centimeters. Now that I've got this here, this one actually has markings on it, as I said before, so I could see that 60 to 62 is listed on here. But another couple of ways that you can mark it, as I discussed before, you can use an indelible marker and open it up and put a mark on here. You can actually have a piece of tape open and you could put tape around it if you wanted to, so that whenever you insert it, you can see it. I've done this many times. I feel comfortable that whenever I'm looking at it, I can see the 60 and then up to 2 marks beyond it, so I'll remember 60 to 62 marks. Another thing that you might have is a piece of paper laying over here with a pen where you've wrote down the length, and that way you could keep up with it. There's lots of different ways to do this. So I've actually measured, and I know where the tube is going. At this point would be where I would go ahead and lubricate it up with the water-soluble lubricant, but as I said, we don't use that on the mannequins, so I have already lubricated him with the appropriate solution. I need to make sure that all the rest of my equipment is set up here and I'm prepared. I need to also make sure that I have a stethoscope, because one of the other ways to verify placement is actually to inject air through the tube, and some of your agency policies require that. So I will discuss that when we get to that point. It looks like I have all my equipment here and I'm ready to get started, and so I'm going to go ahead and put the rail down here for Mr. Smith and make sure that I am staying here with him, and go ahead and let him know that we're getting ready to begin the procedure. Now, whenever we initially get ready to start, some of your textbooks will have the patient actually lean his head back to start with until you get the tube back here to the back of the nasopharynx, and then they have the patient put their head down, okay? So I'm going to have him do that, and of course the mannequin can't move and during all this procedure. I'm going to put some gloves on at this point because I could be exposed to gastric secretions and all of that. So I'm going to go ahead and come over here and put me on a pair of gloves, making sure that I'm watching the patient since the rail is down and that there are no issues. Or you could put the rail back up as you step away from them to make sure to maintain patient safety if you're further away than you feel comfortable with. All right, so one last thing I might want to do before I get started with the insertion. Very commonly, once you get the tube in, you're going to need to tape it to the side of the patient's face if you don't have an assistant holding it for you. So you might well want to come through here and just pull you a piece of tape before you begin, because otherwise the tube will be sitting in there in the patient's nose and you won't be able to take the time to pull the tape. We don't usually recommend that you put it on the table because the table could be dirty. So one thing that you could do is kind of put it on the package there, but make sure it's where you can grab it and get it loose. Or if you had an assistant, then certainly they could, hold the tube for you while we're going through and doing this. The tube would already be pre-lubricated with the water-soluble liquid. We've already measured it. I'm going to go ahead and again explain to Mr. Smith that this is going to be a little bit uncomfortable. Whenever I'm going in with this, his first inclination is going to be to reach up and grab the tube. We want to explain to him to make sure that if he needs me to stop, please ask me to stop, but not reach up and grab the tube, because very often whenever they grab it and they try to pull on it, it's already in place and it could be very uncomfortable for them. So I've got him holding his emesis basin with one hand, and he's holding his drink cup over here with tap water in it to assist with passage. That usually helps keep the patient's hands kind of occupied to keep them from reaching up and grabbing. Before I'm ready to begin, I would have assessed his nares, and I would have made sure which one he's breathing better out of. That would help assist with ease of passage of the tube. I also would wanted to make sure that he has not had any recent nasal surgeries, because there could be an open communication from nose into other cavities up here. And he has not had any recent surgeries. I know the purpose for the tube. Other assessments that I would have done before would have included abdominal assessments, certainly including bowel sounds. Okay, and his bowel sounds could either be absent, potentially. They could be hyperactive, hypoactive. They range. It depends on what the reason for the placement of the tube is. He could also have abdominal distension, nausea, vomiting, discomfort. So always make sure you assess before so you can compare your assessments afterwards. I'm going to have him, according to your skills checklist, lean his head back at this point. The tube is lubricated, and I'm going to get the tube to the back of his throat, which is probably somewhere around the 10 to 15 mark. Once I get to that point, he now needs to lean his head down, and I would have him start drinking. The drinking eases the passage of the tube and allows it to pass into the esophagus and down to the stomach. As I start inserting, I'm going to go ahead and insert quickly, and I need to be monitoring him for signs and symptoms of distress, which would include the cyanosis, the trouble breathing, any complaints of difficulty breathing. I'm also monitoring for how far I am down in here, and I had already identified for him his epigastric area would be somewhere down around 60 to 62 centimeters. Another thing I could do at this point, if I was having any difficulty, you certainly do not want to shove or force the tube at any point. You could take your pen light and your tongue blade and you could look in here in the patient's mouth and make sure that it's not curled up in here. If it is curled up, you may have to pull it out and start all over again. If your patient starts having a decrease in the pulse oximeter or complaints of respiratory distress, you may have to pull it out and start over again. At this point, it looks like I'm where I need to be. So what I'm going to do is come over here and get my piece of tape that I've already pulled up and ready for this purpose. And hopefully it will come off of my package. And what I'm going to do is go ahead and very lightly tape it to the mannequin or Mr. Smith's cheek. And you don't want real bad adhesive tape here, and you don't want to get it